Hello, everyone. My name's Alexander Arders. I am a physician assistant up at Hershey Medical Center. One of the PAs in the ER there working. I'm also an EMT, worked at Warwick for several years. I think my last stint finished up 2022 in the spring. Have my master's physician assistant studies and also my bachelor's as well. So I am going to be presenting on SIRS, sepsis, and shock, what to look for from an EMS standpoint. I did a similar presentation last year. I've changed a few things around, but overall it's mostly pretty similar. And hopefully some of you guys are the same ones from last year that kind of remember this. And similar kind of setup. We're going to go through a few slides here. We're going to go through the definitions, the epidemiology, etiology, pathophys, H&P. You guys can read there. So that's kind of the outline here. So I'm going to stop sharing here and then we'll get started. Okay. So definitions here. So there's a couple things when we talk about sepsis. It's not all just, sepsis or bust. There's, kind of multiple progressions of that. So first thing you look at, and, a lot of hospitals will have this too as like patients will trigger, in quotes, air quotes, SIRS alerts. So systemic inflammatory response syndrome. What even is that? So it's a dysregulated immune response, and there's also inflammation. You can see these SIRS responses even in the absence of any sort of infection. So have SIRS, it has to be greater than or equal to 2 of the following. So the ones I have highlighted in yellow are going to be stuff that you're going to see on the truck or from any EMS standpoint. And then the other ones, lab results or stuff you'll see in the hospital. You might see that if you're, discharging, or if you're getting a patient discharged from the hospital or you're bringing them back, or if a nursing home has some labs drawn on patient and you get the old, call for abnormal labs and transport to the hospitals, so the white blood cell count down there and the neutrophils. So big one's going to be that you're going to see, vital signs on every patient. So that's going to be temperature, greater than 100.4. That's where we say is a temperature. Anything less than that is not considered a temperature. But you also see in some cases, you'll actually see patients that are hypothermic, which can be actually just as deadly as well. So stuff to look out for. If you get like a weird reading, it may not be your temperature probes being off. It may actually be the patient is truly hypothermic from some sort of infection. So heart rate greater than 90. Something to look out for here. We start getting the tachycardia range, definitely a sign of possibly infection. Can also be fever related. How many times we have a kid or even a young adult that will have a fever in the setting of tachycardia. Tachycardia is a response to the fever, but still something to look out for. And the respiration rates, greater than 20, so greater than the upper limit normal there. Just some other thoughts here. The causes of like non-infectious SIRS alerts would be, something like pancreatitis, thromboembolism like DVTs and PEs, burns, surgeries, and other autoimmune conditions. So like I said, not always infectious related, but you can still have SIRS in other situations. So let's continue on some definitions here. So now we get past the SIRS, then we get sepsis. So we have the SIRS, like we just talked about. Now we have a documented or a suspected infection. Don't always have to have a root cause, like a known infection. It could be, suspected or something like that. Obviously, if you think it's something coming from the abdomen, you're not going to be able to see through that without, CT scans or X-rays or even like that. So severe sepsis, that's when we start getting the organ dysfunction, the hypotension, hypoperfusion, and septic shock is when we're requiring the vasopressors, or they're still hypertensive despite any sort of fluid resuscitation. So common sites of infection we're looking at, especially, in the pre-hospital, is urosepsis. That's a really big one. Also pneumonia. And shock is something to be wary of, is when the body is finally decompensated. It is no longer, keeping up with what's going on. So some epidemiology similar to last year, still very, very deadly. We have 1.7 million cases a year. The mortality rate, you can see it right there, is extremely high. If you get to the shock point, I mean, it's just under 50% death rate, which is, very high. if it comes to that point. So still a top 10 cause of death. Some other interesting facts I saw on the CDC website, 1 in 3 people who died in the hospital had sepsis at some point. So that's a third of your patients, essentially have had, if they die in the hospital, they had sepsis at some point. And then sepsis is not often always caused in the hospital. A good many of these patients had it before they even got there, or at least the infection. So let's get into the etiology of, where are these coming from? Like I said a couple of slides ago, pneumonia and UTI, that's going to be the really common ones. A lot of the elderly population, probably a lot of the ones you'll see as well. Just overall not as conditioned and, really susceptible to pneumonia and UTIs. The bacteria still remains one of the most common organisms. The community-acquired one, the infections, that's going to be patients just out in the community, either at home, nursing homes, anything like that, anything outside of the hospitals. Hospital-acquired, that's going to be that can be different kind of organisms, different kind of bacteria, even resistant bacteria. So think of those as your hospital-acquired ones. Anyone that's presenting with the fever, the SIRS-like or sepsis-like syndromes is recently discharged from a hospital, whether it be Warwick that brought them home to one of the nursing homes in the area, and then it seems like a day later you're bringing the same patient back, or with the nurse telling you the history that they just got this patient as discharge, within the past few days, and now they kind of alter mental state or something like that. So something to be wary of. So hospital acquired, they have all kinds of lines in them when they're in there. Say IVs, urinary casts, may have been intubated at one point. They might have had a recent surgery. They might have been in the ICU. Any one of these can predispose patients to these bacterial type infections. And bacteria is not the only thing that can cause sepsis. We can get non-bacterial and fungal and viral. So think of fungal, maybe recent travel to somewhere out of the area, and viral would be the flu. RSV is big this year, and then COVID as well. I've seen a lot of sick people from the flu, especially, not as many from COVID in recent months, but a lot from the flu. And then you get a lot of the kids with the RSV being so bad this year. So let's get into the pathophysiology of it. What's going on in sepsis, and why is the body responding like this to some sort of infection? So you get an inflammatory stimulus. So one of the etiologies, some sort of infection, pneumonia, UTI, some form of bacteria, virus, whatever it be. You're having these this infection's causing a pro-inflammatory mediator, cytokines, and you're getting hypercoagulable. You get microthrombi. And then you have a dilation of blood vessels down the line there too, which is causing your hypotension. You're not, the garden hose with the blood in it, or the garden hose with the water in it is getting bigger. It's vasodilating, so you're not having as much pressure. So then the body realizes this, hey, our blood pressure dropping. We have to start shunting the blood flow to, what's really important, the heart, lungs, and, other vital organs like the brain. So then we start getting, decreased capillary refill because there's not as much blood flow going to the extremities and farther away from the heart. Also, we have the increased cardiac output to try to compensate for this. You see that in the tachycardia. So the combination of these microthrombi, hypertension, shunting, we all around have poor oxygen delivery to these end organs. So let's look at some signs of these end organ damages that we talk about when we get in sepsis and septic shock, and really down the chain there. So big one, cardiovascular. We're going to get the hypotension, decrease mean arterial pressures. Anytime you need vasopressors to keep these up, we're having cardiovascular collapse there. Poor cap refill. Think of greater than 3 seconds, things like that. And then you get the warm, flushed skin, and then even really late you get the cool and mottled. So if you're having cool mottled skin, just realize you're late on in that sepsis, septic shock area. Respiratory, that's where we get the tachypnea and respiratory distress. And then we do a lot of end tidal CO2 as well, so less than 25. That's one thing to look at. So that when the end tidal CO2 is less than 25, that means the CO2 is not being expired in a normal rate. That's because we're having a lactate buildup, lactic acid in the body. So we're more acidic, carbon dioxide being an acid in the body. We're trying to blow that off. So we're getting tachypnic. So think about that. So we're tachypnic. So we're trying to blow more oxygen or blow more carbon dioxide off. That's why you have this drop in the end tidal CO2 to less than 25. We're just trying to push that acid out of the body to make up for the lactic acid, the lactate that's growing in our body. So we're trying to equilibrate our acid base in our body to become more basic. Okay. So let's look at renal too. So that's when we're going to get like the kidney type injuries where we're decreased urine output. Good tip's going to be asking these patients, have you been voiding normally? Have you been voiding less? Obviously, if they have a chronic indwelling Foley, if the nursing staff knows, hey, what's the what's their voiding been? Has it been normal? What's their I&Os kind of deal? GI, that's where we're getting abdominal pain, decreased bowel sounds, no bowel movements at all. Like, even though it seems like every patient is chronically constipated, but this is going to be kind of different than normal. And hyperglycemia too. We see a lot of this in our diabetic patients, but something to be wary of. So like without a known diabetes, so blood glucose of greater than 140, whether that's undiagnosed diabetes or it could actually be related to some sort of sepsis, and the body's not being able to make up for this with the insulin and glucose. And then you get the hematology, the platelet drop. You can get some easy bruising and sepsis, and then your CNS, so central nervous system. That's going to be where we start getting the altered mental status. Maybe a little bit confused, obtunded. You get maybe we get some aggression that's totally off baseline, than these patients are at normally. So history, this is where we start getting into it, and this is where we start to find all of our answers when we first get to the scene and we talk to a patient. So history of present illness, the HPI there. So hey, like what are the symptoms like? What's going on? Why are we here? Cough. Are we having recent urinary symptoms? Hey, we have burning urination a couple of days ago. Now now they're all confused and now they have a fever. Any other pain anywhere else? Any rashes? This is where we start getting it. Were you hospitalized recently? Did you have a surgery? Are you up to date? Have you had all your immunizations? Any recent travel anywhere? So sometimes, as we know, the patients aren't really able to give us history. If we can ask the family, flag down a nursing staff too, like, see if they can give us something here, because it's going to be important. It's going to speed their care up once they get into the hospital, especially if they're confused and they can't give much of a history. Anything we can get going into the hospital will be helpful. So past medical history, do we have diabetic, immunocompromised, cancer patients, HIV? We see a lot of cancer patients and chronically ill patients at Hershey Med. So something to always be aware of. A lot of these cancer patients are severely, even mild infections can cause sepsis in these patients. So it's something to be wary of. And social history, this is our drinking, alcohol, drug use, sexual history. So something to be always aware of is intravenous drug use. Patients are really predisposed to having really bad infections, endocarditis, things like that. Even in otherwise, supposed healthy, 20-year-old, if they're IV drug use, just think about that and the new changes in vital signs and sepsis and shock-like behavior. All right, it's getting into our physical exam past the history. Lungs, heart, abdominal, skin, neuro. You're pretty much doing your full physical exam like you normally do on all your patients. You can be a little bit focused if you need to, if you really think something, the sepsis or the infection is stemming from some area. So, pneumonia, listen to those lung sounds best you can, especially on your way out to the truck before the truck gets on. You're going down the road, so you can really listen to them. Bowel sounds. Look for any obvious rashes, skin, abscesses, things like that. There's an indwelling Foley. You got to note that urine output and get a time how long it's in there. If there's 100 in the bag, ask the nursing staff, hey, is this like all day, or it's 8 o'clock and this is all they've urinated all day, or is this new, or where are we at here? Any time there's decreased urine output, you can get that's evidence of a kidney injury, poor perfusion, and organ damage, like we talked about. And then any indwelling CAS reports, those are common sites for infection, the swelling, the redness, the drainage from the area. again, some of the cancer patients that have, forecast for chemo or anything, they're gonna have an access, underneath their skin to get infection. So it's something always to be wary about. And so something I always, that the EMS standpoint might get and find a little bit funny is, I always talk about that, 90-pound grandma that, thinks she's Mike Tyson incarnated, or reincarnated, when she's got the ultramental status from that UTI she's got. But something to think of, we see that a lot, these, whether it be family nursing home staff, and they're like, oh, Betsy was totally fine yesterday, and now she's swinging at all the nursing staff, and is screaming profanities down the hall. Obviously something has changed acutely, and something to be wary of, and that could easily be infection or signs of early sepsis. The vital signs, these are the big ones. We're getting multiple sets on every patient. So like we talked about with the SIRS and other stuff, tachycardia, fever, tachypnea, hypotension. Think about these two. Think about medications, and you got to think about the whole picture when we're getting into the vital signs. The heart rate, you might be like, well, this person has, looks like cellulitis or an abscess, or looks, has pneumonia, but they have a fever, they're tachypnic, they're hypertensive, but their heart rate's 60. Why is that? Look at their meds. First of all, do they have a pacemaker? Second of all, do they have, some metoprolol? Do they have other cardiac meds that's not allowing their heart rate to increase at all? So that can kind of be a hiding point. So something to think of, that these patients might be on some kind of medication that are blunting their response. Also, chronic steroids or old age, you may not get a fever in that. Other things too, chronically hypertensive patients, patients that just from a baseline, either they're not medicated or they're not well controlled, 170s over 80s, whatever. These patients that are living at these numbers, they can theoretically be hypotensive at what a normal blood pressure is. If someone's living in the 170s or 180s on a baseline, and then now they're 120 over 80, oh, that sounds perfect. But you look there, greater than a 40 systolic blood pressure drop, 180 to 120, that's 60. That patient is hypotensive for them. Maybe not on a normal vital sign scale, but for them, they've lost a lot of pressure there. All right, so let's get into some other stuff here. So we have a couple diagnostic scoring tools. You can use them, you can not use them. Some they might be helpful for you. So QSOFA, that's often used, quick sequential organ failure assessment. Used a lot inpatient, just like the next one, called the NEWS. So the QSOFA, it gives this is kind of likelihood of quick assessment for a sepsis, or potential sepsis as well. Sort of like SIRS, but like respiration rates, instead of 20, it's 22. Ultramental status, a change in GCS, and then hypotension there. So you could use this if not meeting SIRS criteria. Just think a patient has ultramental status or something like that, and they're tachypnic only. But whereas SIRS, they wouldn't meet anything because the heart rate, no fever, blood pressure's fine. But for the QSOFA criteria, they do meet, likelihood of sepsis there, even though they don't meet SIRS. So NEWS, National Early Warning Score. There's a couple different parameters that this is used. This is in hospital, the risk of death, and indicates the urgency of the response and the required response for these patients. Again, in hospital, not pre-hospital, but is another thing to look at. And you can at least see that SIRS and other criteria, they are using a lot of the same parameters and some objective findings, like with the the heart rate, the blood pressure, respiration, things like that. So there's 7 different parameters here. Here's some scoring of them as well. So this is on one of the MD Calc apps. So these are all the parameters. You get different points for them as well. Again, we're getting the heart rate, ABPU, which we have, if I remember correctly, we use that with our charting. Okay. So, also with NEWS scoring, the highest score possible is 19. But then, we get into the different categories. So anyone from 0 to 4 is a low risk, 5 to 6 medium, and 7 or higher is a high risk. So pre-hospital diagnostics, what are we doing pre-hospital? What can be helpful when they hit the door, before they hit the door in the ER? And, what's our plan of action here? So getting EKGs in these patients, especially if you're having, tachycardia, bradycardia, any increased respirations, it could be cardiac related, or it may not be, but you can see some signs of ischemia, even in, real bad sepsis as well. So, blood glucose, like we said, greater than 140 if no history of diabetes. You might also see, a diabetic that is supposedly well controlled on medications and their blood glucose is 300. Something you need to be wary of, as well, because even if a diabetic, they shouldn't have sugars in 300 if they're on medication and well managed. Capno, like we said, anything less than 25, something to be wary of that. Blood draws, I know not every hospital takes these. Last time I think UPMC Lidditz was, I'm not real sure who is, but this can speed things up a lot, because a lot of times anyone that we think has sepsis is getting a bunch of labs done, and also blood cultures. So anything that can help speed up the process will be beneficial. We can run the blood quicker, and if we can't get IV access or something like that, obviously monitor your pulse ox, oxygen is needed, your maps. So mean arterial pressure, systolic blood pressure, diastolic blood pressure, very, very important. Mean arterial pressure, that's a better judgment of how well the perfusion is around the body. So that's kind of standard, and a lot of our monitors will calculate that for us. The goal is to have above a map of 65. That means there's overall good perfusion everywhere, and that's sometimes when we do vasopressors in the hospital or fluids, we shoot for that like 60, 65 number is a good goal to reach. So the point of care lactate, we talked about this last year. There are some, kind of almost like a point of care glucose that I see some, at least from my readings, I've seen some pre-hospital groups have had. So we measure lactate a lot in the hospital, perfusion status, also with acid-based stuff, if they're acidotic or things like that. So we use it for sepsis, hypovolemia, shock, everything like that. So normal lactates are below 2. Not sure if this is something that can be rolled out EMS. Like I said, I know we talked about it briefly last year. I'm not sure if it's a possibility or not, but something to be wary of, because I've seen some studies where it is used, and that's a good monitor of how much fluid we need to give. So something to be looking out for. All right, so let's get into our treatment section now. So we've done, the history, physical, diagnostics. Now we're going to get into treatment. What are we doing to these patients? What are we doing for these patients before they get to the ER? Sometimes even before we're calling the hospital. So if you have any suspicion and the hospital has a certain criteria or a code sepsis alert, definitely something to do. It's better to be wrong, and then then they'll be evaluating the ER regardless. They're going to the ER. But if you can speed something up instead of sending in the waiting room because, hey, we activated a code sepsis, or they're actually going to get a room, or they're going to be seen a little bit quicker, that's going to be of utmost importance there. So, and obviously, like everyone always says, ABCs, airway, breathing, circulation. It doesn't matter if they had 2 liters of fluids on the way in, you're doing all this stuff. If they haven't been breathing the whole way, then it's not going to be very helpful for anyone. Okay. So now we got more treatment stuff. So obviously, any issues with airway, any issues with altered mental status, think GCS less than 8. A good rhyme is GCS less than 8, must intubate. Something to consider. So consider intubation early if you need it. 2 lines, absolutely. 18s or 20s, it's going to be big, because if you need to run fluids through one, vasopressors through another, vice versa. If in the hospital they need to run vasopressors or fluids through one, and then IV antibiotics through another, going to be utmost important. If you can get it, do it. So even the patient's normotensive, but you think this patient's heading down the sepsis train, I would definitely consider at least a 250 bolus. Just give them something to get going. Obviously, bolus and repeat if you need to. Depending on how far you are from the hospital, if you have a longer trip in, 500 repeat, 1,000 repeat, whatever you can do if they need it. So obviously, if they have a history of CHF, or they look really fluid over already, they have fine crackles, both lungs, or really have a lot of pitting edema in the lower extremities, something to consider. But if they need it, if they need the fluid and you think they have sepsis, give it to them. They can always receive diuresis in the hospital later. They're going to get the chest x-rays to see if they have, pulmonary edema, things like that. It's better to have some fluids on board, and then we can diurese later than, come in and you didn't give them anything because you were scared of causing some fluid overload. Again, vasopressors for the medics, epi push doses, infusions, and then I believe you guys also have dopamine too, in terms of vasopressors. And obviously larger bore IVs is going to be better than for running these vasopressors. Running epi through a 22 versus an 18, that's a major difference there. But either way, IV fluids is the first line when dealing with septic shock, even if they are hypotensive. They got to get fluids. They got to get fluids before starting all these vasopressors. All right, so let's talk a little bit more about vasopressors for the paramedics. So norepinephrine, Levophed, that's a gold standard in the hospital. That's like if fluids aren't working, we go to norepi. However, it's not carried pre-hospital. So from what I've seen, PA protocols, you have dopamine and epi. Seems like epi is going to be the best case. I see a lot of them. I see a lot that more used than dopamine. Just some things to consider here. So you got with dopamine, you have heart rate and stroke volume increases. But you have the risk of tachyarrhythmias. Anytime you increase heart rate, you can cause a tachyarrhythmia. Epi, kind of same kind of deal. Can falsely elevate lactate levels though, because you can have some skeletal muscle metabolism, and you can also decrease perfusion in certain areas because you cause that vasoconstriction. Like I said, it seems like whatever you would come down to would be more comfortable, but I do question whether epi might be a little bit easier to titrate than dopamine. I'm not sure. I haven't done much of dopamine, but I don't ever really see anyone in the ER using this as a vasopressor. It's pretty much norepi and epi. Like I said, with epi, you can do push doses. I did see this is also in the PA protocol, how to make a push dose epi here, so you can read over that. We use this a lot in the ER too. Anytime rapid sequence intubation, if anyone is slightly hypotensive or they need to treat it before they undergo intubation, these are often used to push to prevent that hypotension once we give the induction and paralytic medication. All right, so some different patients to watch out for that aren't going to be your stereotypical or your easier patients that have these overt changes to their vital signs. So lower threshold of fever in elderly, something to consider. They may not pop a fever. They might not have the 100.4 fever. It might be 99, 100. They might have some more subjective, some kind of chills or kind of not or feeling hot at home. Patients on these chronic steroids are going to have a blunted immune response, and essentially they're chronically immunosuppressed. So think about that. They're going to be at a higher risk of having worse outcomes from certain infections. So younger patients they might have some severe prolonged tachycardia, and then they'll eventually have that acute hypotension. Think your kids, things like that. They're going to crash really hard on you. So just so you know, at least at Hershey, any kid that's under 60 days old and definitely under 30 days old has a pretty extensive workup, including lumbar punctures, bunch of labs, and they come in if they have a fever at that young because of how much at risk for sepsis they are. So something to consider when these kids are coming in. They should, if they have a fever and they have any signs that might have sepsis, good idea to start a line, give them fluids a while you're waiting for them to get in there, because they're going to have a pretty extensive workup when they get in. And again, getting that good history from the parents for these young kids is going to be of utmost important. If it was, COVID or, RSV's been going around the house and they got a little cough and fever, that might save them some of a workup, some pretty extensive stuff in the ER, but definitely something to be considered. And like we said earlier, your cardiac history or chronic hypertensive meds, beta blockers, you're not going to have the heart rate above 100 if you're on metoprolol, twice a day, and your heart rate's just chilling in the 70s at a baseline, or if you have a pacemaker or something like that. And like we said, hypoperfusion can occur with someone that runs in the 170s, 180s on a daily basis and is not managed on blood pressure meds. So these chronically hypertensive patients may actually be hypotensive with essentially normal blood pressure. It's actually, you'll actually sometimes see it, patients almost come in with like stroke-like symptoms. You'll get the whole stroke alert come in, you get the CT scans, and you find out, oh, they're dehydrated, they're a little bit hypotensive. You rehydrate these patients, they're not septic, they aren't having a stroke, it's almost like a stroke mimic, because these elderly patients just cannot tolerate this hypotension and hypoperfusion. So let's sum it all up here. So you got to recognize sepsis. It's something you always got to be wary of, especially during the colder months. It seems like everyone's sick, RSV going around, in whole nursing homes getting, infected with COVID, other respiratory type things. And activation of code sepsis if you suspect it. Don't be afraid to do it. If you're a basic, if you're a paramedic, it doesn't matter who you are. If you're realizing you're a minute from the hospital and you're like, oh, I should have called a medic or something like that, just call the code sepsis. Either way, they're getting in the ER, but if you can possibly save a life or expedite some of their lab work, it really might make a difference with these patients. So know your protocol, know your meds. Yeah, obviously big ones is going to be your vasopressors for the paramedics, making those push dose epis, using dopamine if that's what you feel comfortable with. Watch out for those black sheep. Like we talked about, those chronic steroid patients, chronically hypertensive, cardiac meds, things like that, and push those fluids early. But like I said, it's a number one. That's a first line treatment for sepsis is fluid resuscitation. That's the first thing we do when patients come in. If we think, if we're doing infectious workup, get them a liter of normal saline or lactated ringers or something like that before we start getting the vasopressors and things like that. All right, some other odds and ends here. We got MD Calc. It's we talked about it last year. I use this app. It's a free app. I use it probably every shift I work. But for some things you might on the truck, mean arterial pressure calculator. For whatever reason the monitor's not working or not getting a blood pressure, and you have to calculate this yourself with getting a manual. Also, QSOFA News is on there, like we talked about, and there's a lot of other stuff too that may be beneficial to you. So pre-hospital antibiotics, talked about last year regarding this. It doesn't seem like it's any much more closer to being rolled out, but I did see a research study, and I did copy the link in here, and I'll send the slides to Steve, and he can send this out if anyone wants to read it. So at least it's a step in the right direction. The 2022 study found there was a major decrease in mortality when these pre-hospital antibiotics were administered early for suspected sepsis. But obviously it does require sufficient training and early recognition of it, and it would have to be a facility that would be willing to accept your blood cultures prior to admission, because this needs to be done in two different sites typically, and two different sets of blood cultures in a sterile environment or sterile-ish environment without not contaminating them, because you're going to be administering antibiotics. But especially when you're bringing patients to these possibly septic patients, possibly infected patients, bringing them into the ER, they might be waiting once you drop them off for 2-3 hours. It's they already have a dose of antibiotics, and that's awesome. That can be very helpful to these patients. All right, so let's get into some cases. I have 3 different ones in last year. All right, so first one. So you transport a 79-year-old woman to the hospital for fever, urinary incontinence from a private residence. Family mentioned the history of frequent UTIs. Initial heart rate when you get it in the door, we hook her up in the monitor, 115, SATs 97, blood pressure 105 over 75. So just thinking right now, what's your initial thoughts? What are you going to do for this patient? Seems like you don't have any temperature here in these vital signs, but it sounds like whether it be subjective or actually, took a home reading and has a fever. So we're already thinking, some sort of infection. We got a history of UTIs, so it seems like that might be the culprit here, and with some urinary incontinence and some kind of change to her urinary habits there. It's got a little bit tacky there, over 115. Really, shouldn't be there if you have a 79-year-old woman who's just essentially resting when you see her. And then blood pressure, you can look at that, it's a little bit soft. So just think about what are we going to be doing next for this patient who's, kind of having these, you know, you got the tachycardia, you got the borderline hypertension, and then they also have the fever. So, we're already kind of meeting SIRS criteria here if you think about it. So just off the bat, you're thinking, okay, infectious, that soft blood pressure, they should, when they get in the truck, they should at least get a 250 bolus something. So we get the IV going, we got started a bolus, perfect, and then 15 minutes away from the hospital, so it must be a longer transport, maybe out in Mannheim or something like that. Now they're becoming drowsy, heart rate increases from the 115 to 125, and now we're getting really soft. So what are we thinking next? So maybe turn up the rate on that bolus. Let's keep giving her fluids there. Biggest thing, obviously, ABC is like, go back to it. Take a second, think about it. Is she protecting her airway? She just became drowsy. What's her GCS? Is she, able to talk to you? Is she handling her own secretions? Do we need to get suction on board? Do we need to intubate now? So geriatrics are just known not to respond well to hypotension at all. We might, younger healthy people might just get dizzy. They might need to lay down and might get like pre-syncope, but these older patients they really do not tolerate it. And like I said earlier, they can even mimic some strokes at some points. So what can we do at this point? We got a bolus running. We can't really do much else, in terms of fluid. We already have one going. We could theoretically start another IV and give more, but we already have a bolus running, and we're dropping blood pressure. So what's our next moves here? So, if you're intermediate, you're going to probably want to call a medic at this point with this severe hypertension, because 15 minutes out, this is not going in the right direction. So we fluid resuscitated this patient, that we had to move over to vasopressor. So we used some push dose epis. We got our maps up to that 65 range. That's a goal that we're talking about. So even if her blood pressure is low 100s, low like high 90s, but her map's 65, that's okay. We're getting good perfusion at that point. So now we start to see her mental status improve. So we're getting those maps. We're getting good end organ perfusion. So hopefully you already started the sepsis activation at the hospital you're going to, so they're aware of this coming in, that you had to use pressors especially, and you suspect there's sepsis versus shock coming in here. So make sure you let these hospitals know about this. All right, next, going on in the case 2. I actually adapted this from one of the patients I saw. So this was a couple weeks ago, actually. EMS responds to class 1 sick person, 60-year-old male, confusion, lethargy, poor appetite, times 2 weeks, had a humerus fracture repair. There's been some nausea and vomiting. Wife reports a little bit of jaundice of the skin, yellowing of the skin, recent confusion from baseline. So there's his history. What do you see? What's in that? It's really important. So think about the hypertension, so they may not be able to tolerate the hypotension. Even so, something to be wary of when you look at the blood pressure. Big thing is metastatic cancer. So this patient has cancer, so they're going to be really at risk of having poor outcome from this. So nothing too crazy. Obviously we get down to the vital signs, and then we start getting definitely some different changes there. So we got a tachy, we got a pretty much hypertensive patient, tachypnic. Glucose is fine, at that, 135. We're getting close to that 140 like we were talking about, but this patient had obvious jaundice, scleral icterus, diffuse abdominal pain. This is all new. And then they look a little bit dry as well, and they seem kind of tired. Not necessarily super confused for me, but they seem more tired. So if this is a patient on the truck, or, you just get to the house, what are we doing for this patient? Like we said, we went over the vital signs. They look different. And then what's important in the history? Oh, he just had a humerus fracture repair. Are we thinking, hospital-acquired infection? What does the wound look like? Is it red and draining? Is it in a bandage? It's going to be you need to take a look at that. But also, we have jaundice. There could be something coming from the abdomen as well. Something to consider here. So this patient met SIRS criteria right away. Respiration rate was high, heart rate was high. And then now we're meeting sepsis criteria too, because we're thinking recent surgical infection or a recent surgery. Could it be a surgical infection? Now new jaundice. Now we have an abdominal infection. Or could it be an abdominal infection or some sort of biliary obstruction? Cholangitis is a very, very deadly disease. It's when there's an infection of the biliary tract, usually from some sort of obstruction or some sort of stasis when the bile isn't moving correctly, and then they have it's very, very deadly. So what are we doing for this patient? So IVs, we're giving them a bolus because they're hypertensive, and we suspect there's an infection. First line, give fluids for sure. Blood draws if they're accept, obviously, hospital dependent, continue monitoring, and then activate the sepsis alert. So to kind of wrap up this one, and this, weirdly enough, this patient came on. I signed them out to the oncoming team when I left for the end of my shift and gave them a fluid bolus, IV antibiotics. We're waiting on some of the CTs to come back, and this patient ended up signing out AMA, believe it or not. Not very bad, not very good, not very good. I'm not sure what ended up happening with them, but they signed out AMA, even with this presentation. Okay, last one here, case number 3. EMS responded to local nursing home. Pick your favorite one, whoever. Maybe it's United Zion, Moravian Manor, or the wonderful Kadima, if it's still called that. Class 3, patient, 74-year-old male, admitted to a skilled nursing facility for rehab following a total knee. Surgery was done 4 days ago. Staff says he become very agitated, confused afternoon, was unable to ambulate this evening. Admitted to the facility last night, so it sounds like he was in the hospital for 3 days after his total knee. And there's not much information known about it, whether, they just got there, haven't gone through his chart yet, or poor sign out, or transfer care, or whatever. So look at his history there. What do you think? So we got diabetes. So, okay, so we're at a risk of infection off the bat. Now, hypertension. Okay, so think about these blood pressures that are, low 100s. So technically not hypotension, but now he may not be able to tolerate it because you don't know what he lives at. And metoprolol right there. So think about that. That's going to blunt his heart rate. So take a look here at his vital signs. All right, look at that heart rate. Yeah, it seems pretty good. I guess you can probably just sign them out AMA, right, and just leave them at the nursing home. They're fine. They don't need to go to the hospital. Nope, metoprolol probably not letting that heart rate go much higher, because you look at the rest of these vitals. He's hypertensive, tachypnic, he's hypoxic. That glucose is way up there. He's diabetic, but he's on. Let's see here. He's on metformin. He shouldn't be in the he shouldn't be in the high 200s, and now he's hypothermic too. So, but his lungs sound clear, so that's good. Maybe not pneumonia, but now we start going into our physical and breaking down that bandage on this total knee replacement. He's got a red surgical incision. So you got to make sure you're looking at all these possible thoughts of infection. So what are we doing? What's our thoughts on this patient? What are we doing for them? Once we get them into the truck and we're shipping off to the hospital. So we got these red flags, these strange vital signs. We had a recent hospital stay. Is it pneumonia? Is it the skin? They probably had a Foley too. Is it we going down the urosepsis strain too? Stuff to always think about when these patients come out of the hospital. They have ports and caths coming all over the place, and that each one can easily cause an infection. So we got SIRS, and we got the sepsis criteria met: respiration rate, blood pressure, and suspected infection. So we need those. We need the hypertensive. We need the IVs. We need the fluid, the high volume fluids as soon as we can. So give oxygen if we need to. If there truly are altered mental status and not protecting the airway, we need to intubate. And then on our way down to the hospital, depending where we'll be going, we need to consider those vasopressors as well. If we're not responding to these high volume fluids, sepsis alert, and then obviously blood draws if they'll accept it. And if you notice too at the beginning of this call, this is a class 3 call. For whatever reason, came out, or nursing staff didn't play it up enough, they didn't know what was going on, or whatever the reason, it happens. If you see this and you see these vital signs like this, and you think there might be sepsis going on, if this is a BLS truck, you need to call a medic. You need to at least get an intermediate there to start a line, start fluids immediately. But you need a paramedic for this, because this patient, if you're going down to Lancaster General, wherever you're going, this is this patient's not going to do well and they need intervention. All right. Well, thanks, guys. It's been a pleasure presenting to you guys again this year. I'll send it to Steve if you have any questions. Again, my name's Alex. I am a PA up at Hershey Medical Center. I was an EMT for a few years at Warwick as well, and I like doing these presentations every year for you and keeping everyone up to date. It's helpful for me to review some stuff and also something to be wary of, because you don't want to miss these kind of sepsis and infections, because these are, especially for our older population, they're very deadly when we see them in the ER especially. So here's some of my references. Again, that one link regarding the pre-hospital antibiotics, I'll make sure Steve has, and he can share with you guys if you guys want. Like I said, reach out if a lot of you already still have my number. Shoot me a text, shoot me an email, something like that, and we can chat. I'd love to clarify anything for you guys. So, and if you're up at Hershey, look around for me. I'm sometimes in the fast track side, I'm in the pediatric side. I'm kind of all over the place. So maybe I'll see you. I've seen a couple of you already. So, all right, take care, guys.